So this morning we're going to go through some of the role of electron microscopy in pediatric pathology, and this will just be sort of a glimpse of that. We do a lot of different case types within pediatric pathology. With this, I'll go ahead and get started. So pediatric pathology and perinatal pathology is really a unique specialty because it extends from the fetal period all the way into young adulthood. And with it, the disease entities that you see are a wide variety, going from developmental, metabolic, hereditary, non-hereditary, environmental diseases. And we also have benign, of course, malignant neoplasms. So electron microscopy still has an essential role in diagnosis, treatment, and prognosis within the pediatric realm. And of course, you know that many of the pediatric entities have underlying genetic and molecular abnormalities associated with that. So in pediatrics, we do a wide sort of multimodal type of diagnosis with our patients. One of the problems with molecular testing is the turnaround time is fairly considerable. Most places you have at least 2 to 3 weeks of turnaround time from the time in which you actually decide to order the test. So I'm going to go through some cases that have a chance for you to take a look at. So this is a 23-year-old woman who underwent ultrasound exam at 24-week of pregnancy. Her fetus had high drops on ultrasound with diffuse severe edema and oligohydramnios. There was no problem with RH compatibility with the child, so it really was not an immune type of high drops associated with this. With this, the maternal serum and amniocentesis were negative for infection, and there was no congenital heart, renal, or pulmonary disease associated with this, no chromosomal anomalies, and there was no fetal maternal hemorrhage or bowel atresia with this. So repeat ultrasound at 36 weeks showed a markedly enlarged liver, akinesis, distal atheroglycosis, and severe cardiomegaly as well as ventricular dilatation. And the child was delivered at 38 weeks with subsequent demise. So I'm going to show you a picture actually of the child at autopsy. And this is what the child looked like. The child survived for a short period of time, but you can see the amount of edema that was present here, the upturned nose, which goes along with the oligohydramnios, and also the descended abdomen that you can see here in particular. So at autopsy, it had impressive splenomegaly, marked enlarged heart, anasarca with abundant clear serous fluid, and severe tissue edema. And the picture you're seeing here is the pericardial sac, which is full of fluid in the heart. And in the background, there's a small area where you can actually see the lung tissue on the right side. So that red, dense tissue. So the lung is really collapsed behind there. So tissue is obtained for many different purposes with this. So one of the things you want to know about is the etiology of hydros fatalis. So it's a very long type of list that typically you can see extending for cardiovascular type anomalies all the way down to not known. And with this, you can see that genetic diseases are also fairly infrequent here, only about 0.4%. So there's many different things to consider when you have fetal high drops in particular. So with it, of course, we've seen this here with diffuse massive subcutaneous edema, the serous fluids in the body cavity, and the incidence in the U.S. is 1 in 600 to 1 in 4,000 pregnancies. Southeast Asia a little bit higher due to homozygous alpha thalassemia. Of course, we have a lot of people that are from Southeast Asia within the U.S., particularly in Houston, so it's always a consideration. And with immune hydros fatalis, you're looking at RH discrepancy is probably one of the major factors associated with that. In this case, that was not the situation. So our situation is a non-immune hydros fatalis. So non-immune hydros fatalis involves either structural abnormalities that you can't see that affect the heart in particular, infections, which is a wide variety of infections, viral are particularly common, and other microorganisms as well. And then you can have masses and tumors such as pleuropulmonary blastoma, cystic congenital pulmonary alveolar malformations, teratomas. You can have polycystic kidney disease that occurs in newborns as well, neuroblastoma teratoma, and you can have abnormalities with the placenta as well that cause non-immune high drops. This is tissue from the thymus, and right away you can see the background of typical sort of lymphocytes in the background. Then you see these very enlarged cells that have very sort of fibrillary look to them, vascularizations associated with these areas, and something that typically you don't see. These are not Hassel corpuscles in the least bit, and you see this as well. From this, we went on just to do electron microscopy, and here you can see the cells that are really massively enlarged and contain this type of inclusion material that really is characteristic for a specific disease. Here you can see a little bit higher power, and you see these tubular type of structures, more longitudinal and sort of oblique type of appearance. Again, a little bit higher power, seeing those as well here. These are about 18 to 20 nanometers probably in size. And here you can actually see cross sections which really confirm that this is a tubular structure associated with that. Also, if you look at the liver, we did electron microscopy in the liver, and you can see similar type of structures here as well. So these features are fairly characteristic for a specific storage disease, Gaucher's disease. And with this, ultrastructural features alone are consistent with Gaucher's disease, and we went on to have mutational analysis done. In particular, we had frozen tissue available for this child, and we showed a GBA1 gene mutation of 1q21. So this is characteristic for Gaucher's. So Gaucher's disease is a lysosomal storage disease. It's the most common. It's one about 75,000. In Ashkenazi Jewish background, it's about 1 in 1,000 births. It's also recessive inheritance. There's 4 types based on clinical signs and symptoms, and the diagnosis can be based upon Gaucher's disease, identifying peripheral blood, bone marrow, and also by looking at glucocerebrosidase activity in leukocytes, or you can do molecular analysis, which oftentimes is done as well. If you look at the carrier state, type 1 is about 1 in 15 Ashkenazi or Eastern Jewish populations. Non-Jewish, about 1 in 40,000. Frequency of Gaucher's disease, different types are listed here as well. There's an adult form, type 1. There's an infantile acute neuronopathic form, with also the perinatal lethal falls into type 2. Type 3, juvenile or subacute neuronopathic. And type 4 is pretty unique with heart valves associated hydrocephalus and visceral involvement. So the adult type, adult form, you see in childhood to adulthood, survival is variable from ages 6 to 80 years. And you can see that it involves viscera, hematologic tissue, as well as bone disease. Type 2 is the infantile acute neuronopathic form, and this is the one without the perinatal natal type of form. The onset is usually within 2 years, within the first 2 years of life or so, and the survival is fairly limited with these individuals. And you can see that it really doesn't have bone disease involved with it. It's pan-ethnic as well. The perinatal lethal form, you can see ichthyosis with these babies when they're born, or colloidal type of baby syndrome with coverage of their body with a thin type of film. And with this is a non-immune fibrosis fetalis that you do see, and usually neonatal or intrauterine death occurs with these babies. The type 3 is one that is seen as a juvenile form, and also associated with Norbothean type of ethnic predilection, as you can see here. And the onset is a childhood. It has variable spectrum of visceral, hematologic, and bone disease as well, but it has progressive neurologic degeneration. The type 4 is the one that's fairly unique, with just heart valves, hydrocephalus, and viscera involved. It has calcification of the heart valves in general, but has really mild to moderate involvement of the other organs, such as liver, spleen, and the bone marrow. There is an association between Gaucher's and Parkinson's disease. With this, typically Parkinson's disease in these individuals occur early onset. This is basically the adult form, and they tend to be resistant to treatment for Parkinsonians. With this, there's specific mutations associated with this, and also Gaucher's may be associated with myoclonic epilepsy, as noted here. So in perinatal lethal Gaucher's disease, number of reported cases 41. And as you know, people don't report individual cases so much anymore, so it's many more than that out there that actually do occur, such as our case. Our cases has not been reported either. You can see that a half of them or so are live-born. You have fetal demise in a fairly significant percentage. And of course, termination of pregnancy is offered oftentimes to suspected type of storage disease such as this. Non-immune hydrops occurs in about 2/3 of individuals, and premature delivery is about 70% or so. And with this, typically, if you have non-immune hydrops fetalis, usually death of liveborns within 2 days or so. And if you have hydrops fatalis is not present, usually survival is a little bit longer. So this is the gene associated with Gaucher's disease. There are over 200 mutations associated with this, with very variable type of mutations associated with it, as you can see here. So Gaucher's disease, there are therapeutic options associated with this. There are synthetic recombinant type of enzyme replacement, but one of the problems with this is you have to actually deliver the enzyme replacement every 2 weeks, and it's a lifelong IV infusion in order to treat this. There's also agents out there that can cause a substrate reduction type of therapy, delaying type of neurologic degeneration. Unfortunately, it's not for children or adolescents, which means it's going to go into the adult form and cannot be used with pregnant women or lactating women. Bone marrow transplantation is an option as well as gene therapy. So these are some lysosomal disorders associated with hydros fatalis. You can see there's many different ones located here. At our institution, we do see almost all of these types of lysosomal deficiencies. Many of these are now really diagnosed genetically, but in the case that we had not had a previous diagnosis associated with it, totally unsuspected, and a de novo mutation that the mother was not known to be a carrier. Okay, so we're going to go on to another case, which is quite different.
Question. Was the child Ashkenazi? Were they?
No.
No, not at all.
Nope. Okay. This is a 4-week-old Hispanic male. You can see these really nice raised lesions that have ulcerated surfaces on them. The kid had a certain amount of fever and recent onset of diarrhea associated with this. This is kind of a picture that people refer to as a blueberry baby, sort of blueberry muffin type baby, which they have multiple type of lesions, such as you see here throughout the body. Actually had quite a few in the face as well. So differential diagnosis from the clinicians, basically, I can see leukemia or neuroblastoma, and infection was less of a consideration. So this is what the clinician was actually expecting. So this is actually an undifferentiated neuroblastoma, has really no type of neuropil associated with it, doesn't show a characteristic neuroblastic appearance to it. Electron microscopy, you can actually see that there are neurosecretoid granules and neuropil associated with this. So this is what they're expecting versus leukemia. Instead, this is what we had, this patient. And you can see right away, we have all these nice reniform cells here. And looking at this is pretty characteristic for Langerhans cell histiocytosis, which is not typical that you see in sort of the blueberry muffin type of situation. This is CD207 Langerhans. So I'm showing you sort of really nice staining of that. And this is a very specific stain for Langerhans cells and Langerhans cell histiocytes. If you go on to do electron microscopy, you can see very beautiful sort of Burbeck granules in here with a sort of characteristic sort of tennis racket appearance to them. They're pentalamellar structures. They have 5 different layers to them. And it actually is called Burbeck granule, but originally when it was described, it was called a Broadbent Burbeck granule. And in some way, rather, Broadbent got kind of left out of the discussion. So I'm showing you this, and one of the things that in an early type of occurrence like this in a neonate, you have other considerations to think about. So LCH by itself is predominantly disease of infancy and early childhood, peaks about 3 years of age, but we do see it in adolescents and adults as well, but fairly rare. It can be a unifocal disease, multifocal and unicystic, or multifocal and multisystem disease, and these are the patterns. If you use the clinical entities terms, you can see those listed here, which we will discourage from using these terms because these are very outdated terms. And basically, you talk about sort of unifocal, multifocal, unisystem, or multifocal and multisystem disease patterns. But if you look at this case more completely, you find these type of inclusions. So not only do you find Burbeck granules with nice type of pentalamellar structures, but you find these sort of laminated appearance, almost fingerprinting type of appearance here. And with this is a fairly specific finding that you have congenital self-healing Langerhans cell histiocytosis. It is described about 4 decades ago by Hashimoto and Pritzker, and called Hashimoto and Pritzker histiocytosis, and also at one time was called congenital self-healing reticulohistiocytosis. More appropriate term is congenital self-healing LCH. It can represent up to 10% of the pediatric LCH cases, and particularly in very young children, neonates, and first year of life. In general, they do have this kind of blueberry muffin appearance, so other things are a consideration in the background. And when you look at this, congenital self-healing is indistinguishable from typical LCH when you look at light microscopy and immunohistochemistry. But if you look at it with electron microscopy, you can find laminated and non-laminated dense bodies, such as I'm showing here. If you look for Berwick granules, sometimes you really don't see those. You see those in less than 30% of the histiocytes. So you have to search for those at time. And if you look at the clinical course, 98% of these will invalid with no treatment whatsoever. So you want to avoid treatment in this very young age group in order to avoid treating someone who has this sort of self-healing type of form. In case you're wondering about the diarrhea this child had, the child actually had viral particles in his stools. And with this, ended up speciating for rotavirus in particular. So it wasn't that they had LCH involving the bowel, which can occur as well. So going on to another case, this is a 3-year-old previously healthy male. He is admitted to a general hospital in the Rio Grande Valley after 2 to 3 days of abdominal pain and upper respiratory tract infections. It's quickly followed by developing yelling of the skins and eyes, and he became febrile. So in his PCP's office before he was admitted, he had elevated liver enzymes, and local hospital these continued on to be elevated, as well as he had coagulation factors that were elevated, and his mental status was declining. There was no etiology for the liver failure that was discovered at the local hospital. He was transferred to our hospital and admitted to the PICU because of acute liver failure, and experienced, a really marked decline in mental status for the next 24 hours. And he was listed for an urgent liver transplant. So before that happened, we actually got a biopsy of this, and I'll show you that before I show you the explant. So his pertinent lab values were, as expected, AST and ALT markedly elevated. Also, alkaline and GGT markedly elevated. His bilirubin was quite high, and his glucose was relatively low, and his ammonia levels were very high, accounting for his mental changes. The coagulation factors were all abnormal. The PCR was done just for influenza A and RSV, and those were negative by PCR. And you can see his factor 7 and factor 5 were decreased as well. So this is the biopsy that we had. And when you look at this, it really doesn't have any type of structure that you could say this is normal liver. With this, basically, we have giant cell transformation that's present. We have proliferation of bile ducts, and we have a great deal of cholestasis. And here, the cholestasis has kind of pink appearance to it. These cells also show giant cell transformation, in addition to just loss of any type of lobular architecture. And with this, you can see again that this is the areas that we had available to look at. And really, none of the areas look like typical liver architecture. Many of the hepatocytes ended up being giant cell transformed. In the background, there are a lot of bile ducts in particular and bile. PCR was done with this, and it's negative for all type of, quote, PCR type of viruses that we can see. So with this, following liver failure in children usually have abrupt loss of hepatocellular function with previously normal liver function. You can see the coagulopathy that this child had, and also the hepatic encephalopathy. And the etiology in children is quite varied. As you can see, many of them are indeterminate and never really get defined up front. Viral etiology is a wide variety of viral agents that can account for acute liver failure in children and fulminant liver failure. So we actually went on to do electron microscopy of this. And with this, you can see that the hepatocytes, this is one that has a binucleate type of appearance here. And we see in the background that, there appear to be areas that look like really a lot of lipid material within this cell. There's a few mitochondria which do not look enlarged or irregular, and really don't see a lot of glycogen in the background, but chances are the cell has pretty much expended most of its glycogen. But you do see this unique sort of area where there's a really well sort of delineated structure here. You look at this a little bit higher magnification, and you can start to see things that look more filamentous and perhaps even a little bit beading to them. And these were not too difficult to find. We found these in many of the cells. And again, they have this really sort of filamentous to beaded appearance to them. And this is true with many different cells. And you can see this as well. And this one's a little bit higher power. Unfortunately, I don't have micron bar on this, but still has that filamentous beaded look to it. These are about 18 to 20 nanometers in size. And overall, this is the liver that was explanted. And overall, this still fits into sort of paramyxoviridia family. And over time, what happened is we actually were able to, put this into paramyxovirus type of family based upon repeating the PCR in general and being more concentrated towards that. So this is a fairly large family. It's RNA virus. That's why you see it in the cytoplasm, not in the nucleus. It's responsible for acute respiratory disease in general. This child had an upper respiratory infection a few days before this happened, and it can go on to acute liver failure, as you see here. I think Sarah's gone through this fairly extensively, so I'm not really necessarily through all this. But in tissue, it's a little bit different than what you see, like if you're doing sort of whole mount type of appearance, where you actually see the virulence quite nicely. Instead of tissue, it really takes on this filamentous beaded type structures that you see there, 18 to 20 nanometers in width. If you look at paramyxoviridia, it has two subfamilies associated with it, and these are some of the subfamilies of those in general. And I guess one of the concerns we have from a pediatric standpoint, as vaccines are being sort of eliminated to a certain extent, and fewer children are being vaccinated, I think our vaccination rate in Texas is hitting around 70%, and I expect it may drop even farther, that we're going to start seeing mumps and measles. And I can tell you that a while back, about a couple of years ago, we had a child that had measles, and the younger faculty had no idea what that was. And of course, we had some of the older faculty walk in and say, he's got measles. That's it. Okay, and isolate the child so he doesn't, expect other individuals. So these are some of the viruses that you see in the paramyxoviridia. And of course, syncytial giant cell hepatitis with paramyxo-like viruses have been described in the past as well, similar to what I have shown you there. Paramyxovirus can be associated with aggressive clinical course and rapid aggressive acute liver failure, as we saw. And ultrasound examination, liver biopsies, or even an explants may help you identify this virus in giant cell hepatitis or other viruses. And we actually do look at our acute liver failure cases with electron microscopy oftentimes, because we can turn around the diagnosis much more quickly than you can necessarily with some of the PCR that is done in-house or ones that are sent out to other individuals. So we'll go on from there. This is an 8-year-old boy presenting to a pediatrician with exercise-induced muscle pain, cramps, and stiffness. He's evaluated for juvenile rheumatoid arthritis, which seems pretty reasonable in this age group. And he started empirically on steroids with no relief whatsoever. And since it became progressive with decreased ability to exercise, continuing on with the muscle cramps and stiffness and routine movement. So with this, he did see the pediatric neurologist. He scheduled the child for a muscle biopsy, and we received only the tissue for electron microscopy, so I can't show you the muscle biopsy tissue, such as the H&Es and all the other special stains associated with that. But I can show you the electron microscopy he had, and I think based upon electron microscopy, we have a diagnosis that probably preceded what happened with the actual muscle biopsy. And this is what the muscle biopsy looked like. And you see all these tubular structures that are present, separated between the typical set of muscle fibers. These are in the area that you see the sarcoplasmic reticulum and typical. And you can see some of them in longitudinal section as well as cross section. And here a little bit of cross sections. It has this very tubular structure to them. And here we see some sort of oblique and intersecting each other as well as cross sections. So this is a fairly characteristic appearance for tubular aggregate myopathy. And here are some pictures from the literature that show you sort of some of the characteristics just for light microscopy. But the tubular aggregate is located in the central portion of myocytes, usually dispersed at periphery of myocytes. Usually the muscle cells, when they have tubular aggregate myopathy, tend to vary in diameter, but the type 2 myocytes are much more effective than the type 1 myocytes. And these are the various types of tubular aggregates that have been described in the literature. There's a vesicular membrane pattern, there's a single wall tubular pattern, there's a double wall tubular pattern, and dilated tubules with inner tubule pattern. All these are in the 60 nanometer range in general. So just giving you sort of variations of the appearance of these. Ours has no difficulty saying it falls into a tubular aggregate myopathy. This condition is a fairly rare condition. It's first described in 1964, and there aren't that many studies out there talking about sort of the prevalence or incidence of this, but it's thought to be 0.24% of muscle biopsies in general. And the aggregates represent usually the major find that you're going to see within the primary myopathy. You don't see other features within the muscles themselves. So it can be sporadic, where there can be familial cases with this. And several cases have autosomal dominant and recessive inheritance patterns in Caucasians. You see the gender ratio more common in males than female, and the age range is quite varied, going from 2 to 55 years of age, and the age of symptoms onset are from 6 months of age on up to 50 years of age. So quite variable in what happens with these. So there's 4 different clinical types associated with this. There's ones that are slowly progressive. There's one associated with exercise-induced muscle pain, cramps, and stiffness, similar to what we had with our particular child. There's ones that have myasthenic features associated with it. And there's others that are slowly progressive with visual changes and gyrate atrophy of the choroid and the retina. This in particular tend to be autosomal recessive. So the tubular aggregates most likely are originating from the sarcoplasmic reticulum. And this is evidenced by the fact that you have this what looks like hypertrophy type of SR cisterns. And also it's been proven that these tubular aggregates actually contain the proteins that are associated with sarcoplasmic reticulum, as listed here. And the major concern about this, there's a disturbance of calcium homeostasis that occurs with tubular aggregate type of myopathy. So there are certain genes that are associated with this. There's a STIM1 mutation that's associated with childhood onset tubular aggregate myopathy. And there's, with this, STIM1 acts as a calcium sensor involved in calcium ion regulation in the SR. And these mutations have been described first in 4 families with autosomal dominant inheritance. And all these had occurrence during the pediatric age group, which we deal with. The clinical spectrum typically have asymptomatic hyper-CKemia and mild to moderate progressive lower limb weakness going from childhood into adulthood. And some of these actually had ophthalmic type of findings associated with this. And as indicated previously, it's primarily a type 2 fiber atrophy associated with this disease process. There's also an AURA1 type of mutation associated with this, and this one has a little bit difference associated with it than compared to STIM1. So STIM1 mutation causes what's called Storm-Morgan syndrome, and this has thrombocytopenia, bleeding, diastasis, meiosis, and a tubular aggregate myopathy associated with it. And this is due to the fact that the calcium release activating channel, calcium channel, is activated within these individuals as well. AURA1 causes this Storm-Morgan-like syndrome, which is congenital meiosis, and the muscular weakness is a less prevalent type of finding than what you see with Storm-Morgan as well. Both of these have inactivation of the CRAC channel. So the current patient, based upon ultrasocial findings, was underwent genetic testing for STIM1 and AURA1, and STIM1 was the missense mutation that was identified with this person. And this really illustrates, the role of electron microscopy in primary diagnosis and guiding genetic testing in particular. And the other thing is, these two aggregates may be seen in several different type of phenotypes, and may actually be involved with specific syndromes that we should be aware of. Okay. We're going to talk a little bit about some small round cell tumors in childhood. And this is just the differential diagnosis that we deal with in pediatric pathology. And as you can see, it's quite wide and varied. And most of our tumors are going to be blastemal tumors, meaning they're not like adults that are coming from, let's say, more differentiated type of cells, but ones that actually can mimic each other quite nicely. Which have cell changes that we recognize to put them in a category before we go on to do anything like immunohistochemistry, electron microscopy, or genetic testing. And going on is still more of the differential diagnosis that we deal with in general. So it's a fairly wide differential that you look at. So I'm going to show you a case that really occurred in a neonate. This is a 37-week gestation male. It was delivered vaginally. At delivery, he had this really large 8-centimeter mass that protruded from the left facial region around the ear, and the mass was not present in ultrasound at 20 weeks gestation. The diagnostic imaging and clinical impression was this is a congenital infantile hemangioma, a vascular tumor. The vascular tumor usually respond quite well to steroids and to beta blockers. And so that's what the therapy was initiated with this child. And unfortunately, instead of invaliding, it rapidly increased in size, and they had to do a resection on day 8. This is what the lesion looked like by day 8. The time the child's gone to surgery, you can see the imaging down below, this massive type of tumor that's present on the face and actually expanding the ear out in particular. This is what the tumor looked like, and you can see right away, this is a very discohesive looking tumor. Really don't see anywhere where the cells are actually touching each other. In the background, you have some areas that look sort of like starry sky appearance, sort of tinge of body macrophages in general. So the initial impression of this was this belonged to our HICKS colleagues. Mm-hmm. And this is another example here as well. And you see a few red blood cells in the background, and maybe some areas in the previous one that maybe have a hint of capillary space. But all these are very discohesive and really don't show any type of solid tumor appearance to them. So here's the flow cytometry results. So CD56, NCAM was positive, CD38 positive. Interpretation of our HEMPATH people, this is not our case. So at that point, we went on to have FISH done for MINIC, which is a neuroblastoma type of marker in particular, had no amplification associated with it. I was actually at the Children's Oncology meeting when this case happened. So I really didn't get a chance to see it until when I came back. And one of the things I was trained was that you don't do more than 4 immunostains at a time. My colleagues basically went through and just emptied the antibody sort of library that we had because they couldn't figure out exactly what it was. They figured, well, we'll do monogenic, no epithelial. Lymphoid was actually our HEMPATH people. Vascular, no. Neuro, no. Including neuroblastoma and other germ cell, no. Monocytic, no. So this is totally against what I was taught. And of course, reimbursed, good luck on that. So when I came back, I was looking at this and said, there are some areas where it looks a little more cohesive. One of the things that impressed me was really it wasn't any mitotic activity of significance here. You see all these cells. You don't see necrosis of the cells. You really just see a few mitotic figures around. And in some places, you see red blood cells are sort of percolating through. And here you can see one mitotic figure in this very large field of cells. You can see red cells that are percolating through. You can see some areas that show some capillary spaces. So to me, this is the sort of the classic type of look of the less differentiated Ewing sarcoma appearance to me. And if you remember, James Ewing did not call him Ewing sarcoma, of course. He called it a hemangiophilia of bone, and he called it that because the red blood cells are passing through these areas, so he thought these were hemangiophilia cells that were proliferating. So even if you call something wrong, you actually get something named after them. So I always tell my residents, that's exactly what you want to do if you want to get named after them. So the only thing that's really positive that all the things that my colleagues did was like Ki-67, you see a high proliferation index, and dot-like appearance to CD99. And I'll tell you what dot-like means just in a few minutes. It doesn't have the membranous staining that you expect with CD99 that you see in Ewing sarcoma, and it's kind of an unusual pattern, but this is kind of a Golgi pattern. So I went ahead while they were still figuring out what's going on, went ahead and did electron microscopy on this. Ewing sarcoma basically looks like a very rudimentary type of cell, usually very little in the amount of heterochromatin. Sometimes it has a little, nucleolus here and there, but very basic, bland-looking cells. Cytoplasm usually doesn't have much of anything in it. Here we can see that it fits into a solid tumor component because it has an epithelial, it has a intracellular type of attachment we see here. And in the background, you can see that there's really not much of anything located within these cells at all. And this is sort of the undifferentiated appearance that you oftentimes see at the basic form of Ewing sarcoma. But if you start looking around, you start to see these nice little neurosecretory granules that are in the cell body. They're not out in neurites. And this is pretty characteristic that you do see in Ewing sarcoma. And you can see the nice halo type appearance to these secretory granules. So when I got the electron microscopy done, I asked our cytogenetics people to do the FISH for rearrangement EWSR1, and it was rearranged. And conventional cytogenetics took a few more days in order to get this done, but had a sort of novel type of translocation of a 2022 at Q1.2 and Q1.2. So this is a translocation that is not typical of Ewing sarcoma, but decided the diagnosis really fit into Ewing sarcoma and had a novel translocation with the EWSR1 rearrangement. And when you look at the candidates at 22q11.2, these are the different candidates that are present there. So there's many different genes associated with this particular site. And if you go through and look at these, you can probably pick out your favorite gene. I don't know if you have one, but when you're dealing with Ewing sarcoma, your favorite gene is this last one, INFAT C2, which actually, upon further study with this, it fits with the EWSR1 INFAT 2C or C2 translocation. And INFAT C2 is known to be associated with various cancers, and particularly breast cancer, and it's associated with cell motility and is the basis for metastases in breast cancer as well. So it's pro-invasive and pro-migratory factor in breast cancer. And with this, this is one of the sort of rare type of translocations that you can have with Ewing sarcoma. So in the older days, people used to do the PCR for Ewing's. Typically, the only two things you get is EWS1 and EWS-ERG. So you would miss this type of translocation. EWSR1 is helpful, but you really need to know the partner because EWSR1 is very promiscuous in many different types of tumors, other than Ewing's as well. So if you look at Ewing sarcoma in a young age group, about 15% can occur before 5 years of age. There are several reports out there of congenital Ewing sarcoma, but very few in general. And searched the literature and found this within the old Armed Forces Institute of Pathology. And with this, they had about 40% of these with metastatic disease at time of presentation, and most died of disease within 1 to 24 months. So when you're dealing with small round cell tumors and neonates, these are the typical type of diagnoses that you're considering as well. And if you look at congenital type of malignant tumors, it accounts for less than 2% of all childhood malignancies. And the most common, of course, is leukemias and neuroblastomas. So this is a very rare type of disease occurring in a neonate. With this, it may be misdiagnosed as another small round cell tumor due to variation in neuroectodermal differentiation. And of course, you know that Ewing sarcoma can have synaptophysin, chromogranin, CD56, and several other things associated with it. The median age for Ewing sarcoma is 15 years of age, not within this age group this child is in, and the vast majority present before 20 years of age. So this is a very unique and interesting tumor for us to see. I just want to show you what Ewing sarcoma looks like in sort of the classic sense. And the upper left-hand panel shows you these back-to-back cells. You can see these little areas where you have these really areas where we have erythrocytes that are passing through. Those are those very dark, electron-dense areas. That's why James Ewing thought this was a heme engine epithelioma of bone. And on the right side, what you're seeing is these clear areas in those. Those are the glycogen pools that you see. And in the old days, basically Ewing sarcoma was diagnosed with PAS stain, H&E and PAS stain, because they had these glycogen pools associated with them. And the lower panel is actually showing some neurites that can occur as you go from undifferentiated Ewing sarcoma to atypical Ewing sarcoma when you start picking up neuromarkers to the place where you have the primitive neuroectodermal tumor of soft tissues, which actually can have neurites associated with it and may have neurosecretory granules a lot of Ewing sarcoma, even the undifferentiated form, will have neurosecretory granules, as you saw in this particular case. Okay, we're going to move on to this case. This is a 15-year-old female with progressive slurring, speech, and drooling. She noted increased size of her tongue without overlying erosion, ulceration, mucosa, and the imaging is seen as you can see here. And she had a very large mass involved the right side of her tongue. And with this, fortunately, she was, you can actually excise the right side of the tongue because, the vasculature of the tongue has a right and left type of supply for the vascularity. So it's possible actually to do a hemiglossectomy without necessarily affecting the other portion of the tissues left behind. So this is the hemiglossectomy specimen. She went away to biopsy first. I'm just showing you the hemiglossectomy specimen. The tissue I'm going to show you actually is from the biopsy. And this you can see intact mucosa overlying this area. And you see this very cellular type of infiltrate below that's separating the skeletal muscle there. Again, this is the same type of imaging that you saw there, with sort of these large aggregates of tumor cells, and separating between them is muscle and some of the connective tissue. And as you know, the tongue has a lot of skeletal muscle, but has very dense fibers within it too to help actually allow you to roll your tongue, move your tongue from side to side, and do various things with it. So it has verticalis, transversalis, longitudinalis muscle, which has many different sort of planes associated with it. And even at this sort of low power in the right view, you can see that these are very pleomorphic looking cells. A lot of the cells don't look like each other. A lot of times when you're dealing with blastema cells, the cells look very similar from one cell to the next. These have very regular contours to them, very high nuclear cytoplasm ratio, very dense chromatin. And then you start seeing other cells which are much more pleomorphic. Some of the cells actually show multinucleation associated with them, and really doesn't declare itself as far as its origin goes. So looking at this, basically differential diagnosis based upon just looking at the H&E is undifferentiated pleomorphic sarcoma versus other high-grade sarcoma. So this was, again, when my colleagues decided to go all out on this and did all these different immunostains. And you can probably pick out your favorite immunostains. And would anybody predict what immunostain would be positive in this particular case? Okay, that's a good answer. You can also do these type of stains, which are more specific for small round cell tumors, such as you see with B-core type of tumors, where you also see with thick duct tumors, where you see ones with synovial sarcoma. And here's the immunostain results. Viment was positive, SMA showed only focal calponent negative, so there didn't have any smooth muscle associated with it. NBM2 and CDK4 was negative, I think trying to see if it was a dedifferentiated sort of liposarcoma, which is kind of doesn't fit very well in this category. It has histiocytes, but these were intratumoral histiocytes. It's negative for myogenic markers, negative for epithelial markers, and vascular markers only with the vessels that were non-neoplastic. So looking at this, if you look at this with electron microscopy, which basically at this point, you're trying to prove that it is an undifferentiated sarcoma versus something else. And I think EM is very helpful in that way, because if you can actually prove that it's some other type of tumor, you've got something to treat, versus saying it's undifferentiated. Basically, resection is the main situation for this particular patient. Looking at this, these are very undifferentiated type of neoplasms here. You basically see that these endoplasmic reticulum is widened in these areas. You really don't see any sort of pre-collagen, pro-collagen within these. In the background, you don't see that the cells are secreting any type of collagen. So fibrosarcoma is not a consideration. There's nothing in here that looks like it's histiocytic in origin as well. And so the cells basically prove that there's no ultrastructural defining type of characteristics. So this does fit into a pleomorphic sarcoma undifferentiated type. And I think the key with this is sort of the last chance you have to prove that this is undifferentiated. And that's very important to do. And I have several cases I'll show you in just a few minutes that really where EM actually provided the primary diagnosis when the original diagnosis was considered to be something else. So we actually did a solid tumor panel on this. We did one for fusions and mutations as well, trying to find if there's something treatable with this particular individual. So tier 1 type of results showed none that were important. There was a CDK4 amplification, MDM2 amplification, and this provides a therapeutic target potentially for this individual. But there was no tumor-defining mutations or rearrangements that we could find. So with this, you came down to an undifferentiated pleomorphic sarcoma. You can see it has this patternless type of architecture. We saw large cells, which have some cytoplasm associated with it, prominently lie, great variation, sort of cell morphology. And also we saw things which actually had giant cells associated with them and very hyperchromatic chromatin. So this is basically the features that you see on undifferentiated pleomorphic sarcoma. So repeating some of those things here, the key is the diagnosis. This is a diagnosis of exclusion with usually only Vimentin being expressed and represents 3% of pediatric sarcomas in our experience too. With this, in the past, actually pleomorphic undifferentiated sarcoma originally was lumped in with an undifferentiated form of rhabdomyosarcoma, but it really lacks any monogenic differentiation whatsoever from an immunohistochemical standpoint, if you do molecular testing with it, and also electron microscopy. So it was moved out of that area and has its own type of therapy associated with it, which is a very aggressive type of therapy. It has a very poor prognosis overall, and is classified by COG in the non-rhabdomyosarcoma soft tissue tumor category. But I want to show you something that probably is something that our clinicians were expecting, in particular for the tongue. And this is from a 12-year-old girl. She had a slowly enlarging tongue mass. It's increased rapidly in size, and you can see that it's very hypervascular based upon the angiogram that you can see in the lower left-hand corner. This is pretty classic appearance, and this is what they were expecting with the last child. And this is an alveolar soft part sarcoma, which, based upon what you see here, this is what you consider instant pattern recognition. And with this, of course, you can see those really nice crystalline structures. If you do a PAS stain on the upper right-hand corner, TFE3 is positive in these tumors as well. And one of the hallmarks for it associated with the translocation it has. And of course, if you go into electron microscopy, you have these beautiful rhomboid type of inclusions, and with this really beautiful pattern of lamination to it. So this is what they were expecting with the last patient, and of course, it did not have that. And when you look at alveolar soft part, typically it has a classic appearance, but sometimes it can be very pleomorphic. That was another reason to do electron microscopy to prove that there were none of these rhomboid structures in there, or even some pleomorphic-looking sort of rhomboid structures. So most of the soft part sarcoma occurs between ages 5 to 35 years of age. Most of them fall within our pediatric age group. It represents less than 1% of soft tissue sarcomas, and it's fairly rare before 5 years of age. The common area in children is the head and neck region. The tongue is the most common, followed by the orbit. In adults, typically are deep soft tissue tumors that occur in the thighs and buttocks. And oftentimes they're slow growing painless type of tumors, so they can acquire a fairly large type of size before you actually discover them. And they can have metastatic disease as well, going to the brain or lung. So this is the translocation associated with alveolar soft part sarcoma. It has the derivative 17 chromosome, and has an X17 type of translocation. So it's ASPL and TFE3, and that's why TFE3 immunostaining is so valuable with these in particular. So with this, you can use MET inhibitors as a target as well, because it activates the transcription factor for this. So typically, locally, they don't necessarily occur if you have an adequate excision overall. It's difficult to get an adequate excision. Metastases do occur with long-term follow-up, and you see the survival with no metastatic disease at diagnosis. Over time, actually, they do develop metastatic disease oftentimes, and overall, the long-term survival is not very good. Prognostic factors, children tend to do better than adults, and the metastatic sites as listed here. But before you sign out alveolar soft part sarcoma, just be aware that you also have the renal cell carcinomas, that are translocation type. Those translocation renal cell carcinomas account for 20 to 40% of all the renal cell carcinomas in kids, even though it's fairly rare to have renal cell carcinomas. And they tend to present at advanced stages, and they often metastasize even if they have a small size overall. Their course is fairly indolent. They have TFE3 expression, and some can actually have mimic alveolar soft parts. This is one of the cases. The last one also was, this is one of our cases here. Fairly large type of tumor, actually going off into the renal sinus and actually the renal vein, and was metastatic at the time of diagnosis. Here's a very small tumor that we had, and this one actually was metastatic at this point. So they tend to metastasize fairly early on. So with renal cell carcinoma, they do share a translocation, which is very similar to what you see with alveolar soft parts, the ASPL TFE3. And so it's always a consideration that you need to rule out that there's not a translocation renal cell carcinoma when you see it elsewhere within the pediatric age group, just to make certain that that is not a consideration. So this is where we used to take selfies. So that's kind of gone by the wayside. But let's go on to this case. This is a 14-year-old male with a bump on his head and a history of possible trauma. The local sort of physician thought this could be a dermoid cyst or an epidermal inclusion cyst, which definitely was not. The mass increased rapidly in size, and imaging showed as an infiltrated lesion and showed loss of cortical plates and considered to be a primary soft tissue feature. The child was referred to an adult neurosurgeon who resected the specimen, and typically in pediatrics, we don't resect specimens, we biopsy the specimens because you want to determine the diagnosis and then determine if they actually are ones that are amenable to oncologic management, and you want to do that in order to shrink the size of the tumor, see if it responds particularly, and probably it's very important in two ways. One, you can reduce the size of the tumor to limit the amount of surgery that's necessary, and two, if the tumor recurs or is metastatic, you know that it responds to certain medications. So this is what the tumor looked like. You see it has sort of a small round cell appearance to it. The arrows are pointing to areas that look like fibrin within this tumor. And this very much looked like a sort of atypical type of potentially Ewing sarcoma, other small round cell tumor. And again, you can see the same similar picture here with this. It had areas which had this kind of fibrinous material that was present. And what I decided to do is I thought that this fibrinous material probably was the fibrinous material. I thought it was probably the earliest phase of osteoid production in this, but they can be confusing. And the easiest way to prove that is there's no stain for osteoid. Went on to electron microscopy and you see the calcifications that are occurring. This is what the earliest phase of osteosarcoma looks like. This case has a small round cell appearance to it. The material looks like it's fibrinous material, actually is early phase of osteoid, and you can see the calcifications on electron microscopy quite nicely here. So this is a small cell osteosarcoma. It's very rare. It's only about 1.5% of all osteosarcomas, but it shares all the clinical radiologic features of conventional osteoblastic osteosarcoma. Typically, these are these cells have scant cytoplasm. They resemble sort of Ewing sarcoma or round cell sarcomas, and sometimes can be mistaken even for lymphomas. They have greater pleomorphism, as you saw with the images I showed you, than typical Ewing sarcoma. Ewing sarcoma is very bland. Each cell looks like the cell next to it typically. And usually it's very rare to scant osteomaterial, and it may be confused with fibrin. So the other thing to consider is Ewing sarcoma can have fibrin around it as well. So these may also have this hemangioparasitoma-like areas associated with them. This tumor follows sort of the pattern that you see with osteosarcoma, this permanent growth pattern with cortical bone that was disrupted. Really didn't see calcifications, based upon sort of the tissue that we have after looking at many of the areas. It's named for NKX 2.2. NKX 2.2 nuclear staining is fairly common with Ewing sarcoma. It can be seen in EWS-FLI1, EWS-ERB, type of translocations with Ewing sarcoma. Small cell osteosarcoma can immunoreact with CD99, and there are reports out there of CD99 being positive, but it's not using a membranous pattern that you see with Ewing sarcoma. Probably the best type of stain you can use for determining osteoblastic lineage is the SAT2B. That's readily available. The SAT2B also stains many other small round cell tumors, as well as round cell synovial sarcoma. With small cell, it has decreased survival compared to conventional osteoblastic osteosarcoma. Okay, so we'll go on to our next case. This is an 8-year-old Hispanic female with the right cheek swelling. She's noted by her parents about a month ago. She went to a dentist in Matamoros, and it's not a tooth problem. I went to a physician in Matamoros. He gave her a cycle there with no resolution. I'm not sure exactly why, because she didn't have any type of herpetic lesions. But I don't know. Went on to Brownsville, working her way back into Texas. Antibiotics were given by a person there with no impediment. There was a dentist in Brownsville that saw her. He said it was a problem due to chewing on her teeth. So he removed her primary molars and incisors. That was no change. So this child has seen many different people with no real effects. So then she had spasms, with pain for about 3 to 4 hours, night without relief. And she ended up going to Valley Baptist Hospital down in the Rio Grande Valley. And they did a CT with what they considered an ankle jaw lymph node enlargement, concern for malignancy. So she came to our institution. And this is kind of the imaging that I've kind of blown that up for you. That's the area that looked like sort of was probably a lymph node of some kind. And this is the tissue that we had available for biopsy. And looking at this, it has a very kind of fleshy appearance to it, which could fit into sort of a lymphoma type of family or other soft tissue tumor. This is what it looked like. Our people could touch press on it, and you can see a very discohesive type of look to this. And really don't see real aggregates of cells, no sort of clumping of cells. And so they were looking at this very sort of variation in size and shape of this, and they thought that it fit into lymphoma, maybe anaplastic large cell lymphoma. So these are the permanent sections that were received. I actually took a look at the permanent sections before they went off to our HICKS people. And looking at this, had more of a solid tumor appearance to me in some areas which are more discohesive than others. And here you can also see that it still has a certain amount of cohesiveness to it. There was one single cell that had a little bit of pinky eosinophilia to its cytoplasm. And so while my colleagues were working up the lymphoid component to it, I decided just to go ahead and do electron microscopy because there's very few cells that had any type of pinky eosinophilia to them. This is one of our technicians working on the case.
What's my favorite pictures?
Very highly skilled. And this is what I found. So I actually found a classic rhabdomyoblast that was there. I found variations, sort of myofilaments, going from areas where you see myofilaments with Z-band material, other areas with very, very rudimentary type of myofilaments, which have a very fine sort of fibrillary structure, and a lot of times it's just attached to little ribosomes. So this took into rhabdomyosarcoma. So after that, ended up doing the desmin and myogenin, and let my HICKS colleagues know that they didn't need to do flow and other things. And so this is an example of a supposed lymph node that actually on the touch perhaps looked like it should be lymphoma, but wasn't. So we did the PCR on this in particular because it was fit into rhabdomyosarcoma. So basically we're looking for PAX7 or PAX3 FOXL1 type of translocation. This patient had a PAX7 FOXL1 translocation, so this fed into an alveolar rhabdomyosarcoma and had more of a solid pattern to it than the typical alveolar rhabdomyosarcoma. This is the more typical rhabdomyosarcoma that we do have. This is sort of an embryonal type of rhabdomyosarcoma. Usually has very little in the way of matrix, maybe a little myxoid material in the background, and oftentimes you don't see a lot of degree of differentiation. There's a few cells in here that have what look like a little bit of sort of pinky eosinophilic cytoplasm to it, a little bit eccentric nuclei, suggesting that these are rhabdomyoblasts. So I'm going to show you some cases that the EM was sent to us to be done, and the diagnosis was given to us, and occasionally we'll get unstained slides and cell blocks, but when we get EM only cases, a lot of times we don't get that. So oftentimes requesting that after the fact. This is a child that had a soft tissue tumor, and they thought that this fit very nicely just to a pleomorphic undifferentiated sarcoma. You can see there definitely has very great pleomorphism to it. It has these really atypical type of mitotic figures associated with sort of an anaplastic look to it. And when we got to the tissue electron microscopy, this is what we found. We found myofilaments associated with this. We found that there was a Z-band material, wasn't present. Every single cell was definitely present. So I asked them to go back and do myogenin staining. And here you can see the myogenin stains very nicely. So this is a alveolar, this is a tumor that actually, they told us later, is a paratesticular tumor. And with this, it fit into a sort of a pleomorphic type of rhabdomyosarcoma. And they ended up doing the translocation on this, and it had a translocation associated with alveolar rhabdomyosarcoma. Another case that was sent to us saying that this is a sclerosing epithelioid fibrosarcoma, and as you remember, it has a specific translocation associated with it that it shares with low-grade fibromyxoid sarcoma. And so it's sent for electron microscopy, but it's also sent to do the molecular testing on it. And when we did the electron microscopy again, we found myofilaments associated with this. We went and did Desmond. Desmond was positive. I'm not showing you MyoD1, but that was positive as well, more commonly, more diffusely positive than what we saw with Desmond. So this is the sclerosing rhabdomyosarcoma, and it can very much mimic other things, such as a sclerosing epithelioid type of fibrosarcoma. And also looking at this, it has areas which actually almost look like the nesting type pattern that you can see with some of the osteosarcomas, or sometimes even with chondrosarcomas. This was sent to us as a fibrosarcoma. Their concern was whether this represented sort of an infantile form. It was in a very young child, and so they sent it to us in order to do the RT-PCR, or the fusion panel that we have, which covers a lot of different sort of fusions. With this, they were interested in sort of seeing if they had an intract, fusion associated with infantile fibrosarcoma. And again, we did electron microscopy, and guess what? We found that we actually have all these beautiful myofilaments. We asked them to do myogenin and Desmond, and those were both positive. So this fit into a rhabdomyosarcoma spindle cell type overall. And of course, it didn't have a densification associated with infantile fibrosarcoma. This was a tumor in the lymph node. They weren't certain exactly what type of tumor this was. And you see that these cells do have very pinky eosinophilic cytoplasm to them. We did EM. We found very rudimentary type of filaments, as you can see in the upper right-hand corner there. And with this Desmond positivity, it was quite nicely present. So, you can show a utility of electron microscopy that can be done very nicely. This was sent to us as a rhabdomyoma, but one of the things you find with rhabdomyomas, and typically they have fairly well-differentiated rhabdomyoblasts, such as you see sort of in the middle of the upper left-hand corner there. The ones that are still kind of ovoid to round type of larger type of skeletal muscle cell. In the right-hand side, the right-hand area, the thing that you need to pay attention to is not necessarily the larger cells, but the smaller cells. The smaller cells actually look fitted into rhabdomyosarcoma. So rhabdomyoma, like rhabdomyosarcoma, originally came out of rhabdomyomas. And this in the past was basically called rhabdomyoma. But one of the problems is that they realized that some of these that had smaller cells in the background actually metastasized. So suddenly now you've got a rhabdomyoma like rhabdomyosarcoma. And they show very nice, of course, muscle differentiation. But the key is identifying these smaller brown cells in the background that are the malignant cells, and not the larger cells that look pretty pleomorphic, but still are in the benign category. And of course, undifferentiated sarcoma, as I've shown you previously, you can prove by electron microscopy that actually you don't have any tumor-defining characteristics with it. Okay. So We'll go on to this particular case. This is a 2-week-old male asymptomatic firm thigh mass, and you can see the imaging on the right-hand side. And next to that, I put the gross specimen that we received. The clinical impression was that it was a hematoma from immunization or lymph node or an abscess. And the ultrasound impression was basically lymph node. So it was about 2.3 centimeters in size. It actually was associated with a semimembranous type of muscle. So the overall impression by clinicians and also the imaging was infantile myofibroma versus infantile hemangioma, but didn't seem like it was that vascular in general. So mass was actually resected and it was triaged. And typically our triaging for any type of tumor, benign or malignant, is to freeze tissue, is to set aside tissue for cytogenetics, do touch preps in case we need to do FISH, and also electron microscopy. So we typically do triaging that's very complete with this in general, and we freeze additional tissue in case other studies need to be done. So this is what the tumor looked like, and you see on cross section of this has a fairly fleshy appearance to it, but it's fairly well defined. It has what looks like a pseudocapsule surrounding it, and this is what the tumor looked like. It had this really very nice intersecting fascicles, fibroblastic type of cells. And this is one of those that looks very much like you see with sort of an infantile fibrosarcoma. You can also see similar picture sometimes with a cellular myofibroma, but those typically have hemangioperiocytoma-like vessels within them as well, and a little bit more variation in the cellularity. So this looks like it could fit into an infantile fibrosarcoma. So what you expect for an infantile fibrosarcoma is what you see on the right-hand side, very cellular type of specimen. You'd see vitamin positivity with it. And oftentimes you're going to see a pan-track type of staining with it that would look very much like you see a vitamin. And one of the things that's described quite a long time ago was this really flocculent type of material present within the stroma. And this is fairly characteristic for infantile fibrosarcoma, also for cellular mesoblastic nephroma, which I think is equivalent to sort of a renal infantile fibrosarcoma. So with this was basically to rule out infantile fibrosarcoma, ETV6 and NTRK3 was the most common translocation that you see with these, and the FISH of this was negative. So there are several other translocations associated with infantile fibrosarcoma. And to give you an idea, these are the chain rearrangements that have been described infantile fibrosarcoma. So first of all, a pan-track or N-track doesn't necessarily define your disease for you because there are other translocations that are not associated with N-track at all. And you can see the many different types of translocations associated with infantile fibrosarcoma, as well as BRAF mutations. So it's a very wide spectrum of the disease. So with this, I went on to do
second. You said that they said something about they thought it could have been an immunization from that thigh. Now, how many times do they do immunization from thighs? I was just curious.
Oh, it's not uncommon at all. In pediatrics.
And you think it had anything to do with this?
No.
That was there already, and they didn't. Oh, right.
True and unrelated.
Yeah.
That's true a lot of times in pediatrics. The other thing too is it's not unusual. Like when I was in Miami and doing pediatric rotation in the ER, there's a child who came in with this sudden onset, of sort of she fell today and she had this swelling in her arm, and we took an X-ray and it had this sunburst pattern to it as Ewing sarcoma. And the fact that she fell that day had nothing to do with the fact that she had this tumor. So a lot of times the pediatric information is not so great for onset of disease. So this is electron microscopy, just showing some glycogen sort of accumulations. Again, a little bit of lipid in here, some dilated smooth endoplasmic reticulum, which you can see definitely with fibrosarcomas. Usually in the background, you can see collagen. There's some collagen background here. You're looking for procollagen secretion as well. But then you start looking a little more closely, you start seeing these areas that are starting to look like sort of myofilament appearance of this. And again, another area is myofilament. And then really we found the things we're looking for, and this is having dense sort of these Z-band material intermixing this really fine sort of fibrillary material, sort of the rudimentary appearance that you see with skeletal muscle differentiation. So then we go on to desmin. You can see the desmin positivity here, myogenic positivity, and this is nuclear MyoD1. So this is a rhabdomyosarcoma spindle cell type. And I did a sort of a terrible thing to my colleagues. I showed my colleagues the H&E, and they go, "Oh, great, that's an infantile fibrosarcoma." And then I handed them like the MyoD1. They go, "Oh, it's not." Yeah. So you can be very confused with these. So any infantile fibrosarcoma that I have, I will do other immunostains to prove it's not something else. And EM in this case really helped a lot because I could get that done within a very short period of time. Our EM materials available within maximum of 2 days. We can go ahead and do it at that point. So this one had sort of a unique type of finding that you do see in infantile rhabdomyosarcomas and spindle cell rhabdomyosarcomas. This is a TED1 NCOA2 rearrangement. We always do a FOX1 in these just to make sure it's not, a unusual type of alveolar rhabdomyosarcoma. And Kristin Antonescu a few years back described the NCOA2 type of translocations that you see in these spindle cell rhabdomyosarcomas and congenital and infantile forms associated with these. They had this very distinctive herringbone type appearance like you saw with my particular case, and they look very much like you see with the fibrosarcoma. They tend to be higher grade, they're hypercellular, and they usually have a fairly significant mitotic activity. But you typically see no rhabdomyoblasts at all on routine H&E, and they very closely mimic fibrosarcoma. Also, with the pediatric spindle cell tumors, spindle cell rhabdomyosarcoma, you can find VGLL2 type of translocations associated with this. And these are fairly specific translocations that you can see with this subgroup. So these are the fusions that are currently described with infantile spindle cell rhabdomyosarcoma. NCOA2 has these other partners associated with it, and VGLL2 has inversions on 6q chromosome that involves a sided type of translocation. So the interesting part about these infantile spindle cell rhabdomyosarcomas, no metastatic disease reported in any of these patients. Typically, they may have some local recurrence associated with it, but others really have not had any significant disease overall. And with these, there's a wide range of sort of survival, median survival about 7 years, median follow-up about 7 years. The range has been fairly short. So the big question is, should these be even considered to be high-grade tumors or not? Since really it's a subtype that hasn't been proven to actually metastasize in particular. So that's probably the big concern with these. So you probably with these, they can undergo local type of excision and then follow the patient and avoid chemotherapy if you get complete excision. The other consideration that always you want to think about is MYOD1 mutation, rhabdomyosarcoma. And unfortunately, MYOD1 mutation in rhabdomyosarcoma is associated with very aggressive clinical outcome. And this is an example here of one that has a sclerosing type of rhabdomyosarcoma pattern. You see in the upper right-hand panel, and you can see that it expresses MYOD1 to a much higher degree than what you see with myogenin or desmin. And one of the things that you can find, these are the different type of translocations you can see in congenital spindle cell infantile forms and the sclerosing rhabdomyosarcoma you see in adults. These are different translocations and MYOD1 mutation. These are the mutations that are associated with less aggressive and favorable outcomes associated with this type of rhabdomyosarcoma, both spindle cell and sclerosing. And these are the features that you see with aggressive tumors and a favorable outcome. And recently I had a case that actually had MYOD1 and PIK3CA mutations. So this is a highly aggressive type of tumor, and you need to define this up front. And so typically with the spindle cell and sclerosing tumors, we end up doing, of course, a mutation analysis with this to make sure we don't have a MYOD1 or PIK3CA mutation associated with it, as well as doing the fusion panels. So this case does show the importance of considering infantile rhabdomyosarcoma when considering any tumor that has similar features as you see with infantile fibrosarcoma. And you can see that electron microscopy can really contribute quite nicely to these cases. So I'm going to show you something that Chava showed you yesterday. And I'm going to show you a variation of that. But this is a newborn with respiratory distress, grunting, decreased oxygenation, decreased breath sounds on left side, consistent with airway obstruction. And this is a fine needle biopsy that wasn't done at our institution, but someplace else. And this is pretty unusual for people to do this on a neonate. But you can see this is lung tissue. And as Chava showed you yesterday, you can see what looks like very vacuolated sort of cells with this very widened interstitial areas. And here's a PAS stain. Sometimes you can get the PAS to work quite nicely with this. So it shows that it does have what probably is glycogen. If you want to do a diastase on this, it will digest. Vimentin is positive with these, similar to what he showed you. And then here you can see these cells within the interstitium that are sort of spindle type to round cells that, are seen. And here you can see the glycogen quite nicely. Oftentimes you really have to pay a lot of attention because the glycogen sometimes is not as prominent. It's usually very faint and very, very inconspicuous. Above this, you actually do see a type 2 pneumocyte, has some really nice other bodies associated with it. So this is what this looks like. And having not a really good history, except the fact that this kid has what seems to be, respiratory distress, and no imaging associated with that. And we get something like this, and you say, well, this fits for pig. But we want to see imaging, we want to see what's going on. And so the child was transferred to us. And this is what actually they were biopsying. So they weren't biopsying just the lung, they were biopsying a mass. And so this is a child that had this really well circumscribed cystic mass in the left upper lobe of the lung. And so if you would have just gone by the sort of biopsy itself and not had a chance to get the imaging, you would have said, okay, this is pig, So this is interstitial glycogenosis, pulmonary interstitial glycogenosis. Instead, this is what the tumor looked like. You can see a very well circumscribed type of mass. It has a little subcapsular appearance around it. It's 2 to 7 centimeters in size, and it has very spongy character to it. It is a solid tumor, but spongy looking. But it's very, very well demarcated. It has a capsule around it. And when you look at the tumor, you can see again, it really mimics exactly like pulmonary interstitial glycogenosis. With this, it has a sort of immature mesenchymal cells in the interstitium. And here again, you can see this as well. The surface is actually coated by what looks like perhaps some epithelial cells, but the epithelial cells have a lot of vacuolization to them. And then when I show you PS, you'll see it has a lot of PS positivity to it. And here is actually the PS stain in the upper left-hand corner there. You see sort of some fine staining of that. You can also see that there's a smooth muscle that underlines this kind of rudimentary type of epithelial lining. When you look at this, consideration always is whether you consider this a pleuropulmonary blastoma. Pediatrics, pleuropulmonary blastoma is characterized in 3 different ways. One is pure cystic, one is partially cystic, partially solid, the other is pure solid. And the ones that are tend to be cystic, they tend to have rhabdomyoblastic sort of cambium layer associated with them. Really don't see that. We see sort of more myofibroblastic spindle cells in particular here. And if you go on in the pleuropulmonary blastoma and look at the solid component, you can have any type of sarcoma that you wish to look at. You can have things that look like pleomorphic sarcoma. You can have areas that look like synovial sarcoma. You can have areas that look like chondrosarcoma and various sort of mesenchymal-derived type of cells. Vimentin, again, also here, the SMA just highlights sort of those myofibroblastic cells that are next to the epithelial lining. And with this is electron microscopy, which shows you that the lining cells that are there, they're epithelial in character, but they're full of glycogen. And the interstitial cells actually have a lot of glycogen associated with them too. Of course, the lamellar bodies, in the type 2 alveolar cells that were around show typical type ones as well. So this doesn't fit into a pleuropulmonary blastoma. Looking at this a little more closely, you can see that the interstitial cells have these fibronexus type of structures to it that go along with sort of myofibroblastic type of appearance to it. And with this, again, you can see the capsule surrounding this. It's very well encapsulated type of tumor. Has this really sort of almost a pulmonary interstitial glycogenosis appearance to it. So the diagnosis, I don't expect you to know the diagnosis because it's a fairly rare disease. But this is the fetal lung interstitial tumor. It's called FLIP. And it was described about 10 years ago, cases that we contributed to the literature with that. And currently about 21 cases that have been reported of this. This is a benign tumor. Once it's excised, there was no recurrence associated with it. It really resembled sort of the fetal lung at about 23 weeks gestation. So it's very similar to that. And no one really knows exactly why this occurs as a separate tumor in general. And you can actually see it on fetal scans as well. So as you can see with this, you see the ultrasound in utero, and then you see the fetal MRI scan that shows one of these lesions present within the thorax as well. So this is one of those that shows symptoms that basically respiratory distress, depending on where it's located, how close it is to the bronchus. A lot of times they may have a low-grade fever associated with this, perhaps collapses the bronchi that are away from this area. And they typically are very well circumscribed. And with these, they're usually solid masses. They can be partially cystic masses, and that can be confused with pleural pulmonary blastoma, which is a malignant type of tumor that occurs in the pediatric age group. So this is the differential diagnosis that you deal with: a bronchogenic cyst, congenital cystic pulmonary airway malformation. Usually that involves a lobe and not really circumscribed. A cystic pleural pulmonary blastoma type 1. Pig is unusual unless you get those biopsies such as we saw there. It's not usually a mass of some type. And congenital peribronchial myofibroblastic tumor is something a little bit different. That's more in the central area of the lung. So I've shown you a few zebras, and I'm showing you a few things that are a little bit different than that. And probably I want to show you at least this one other case here. And this is a 9-year-old kid with a 7-month history of right orbital swelling and proptosis. And these images aren't the greatest because the slides were sent to us from the valley. And with that, they didn't send us very good imaging of this. But you can see we have areas which have aggregates of tumor cells, definitely malignant. We have cells on the right that you can see they're very nice back-to-back looking, fairly uniform, looking like each other. And in many ways resemble some of our small round cell tumors, such as what we do see with Ewing sarcoma. CD99, this had more of a cytoplasmic stain. There was a little bit of hint of sort of a membranous staining, but not nice as what you would like to have. The electron microscopy showed this, which had this very bland-looking type of appearance to it, like I've shown you previously, which looks very much like a Ewing sarcoma. And there's some glycogen in there. There are a few little filaments in here, not very impressive. But as we went on to look at other cells, we found areas that have these myofilaments with some Z-band material in them. So we got the cells that look like they have Ewing's type of character to it. Others that look like they're trying to be rhabdomyoblasts. Then we look around a bit more. We find in the cell body some of these nice neurosecretory granules, which fits more in sort of a Ewing category. And we find some areas with quite a bit of neurosecretory granules, and some areas which even have some extension of the cell processes. So if we go back, we can find that Desmond's positive, Mount Jim's positive in some of the cells, NSE is positive in some of the cells, the CD99, as I show you, has somewhat of a membranous pattern to it. It's cytoplasmic. And so translocation studies were done. This was done during the time we did PCR on these. And this particular tumor had EWS flag 1 rearrangement, as well as a PAX3 Foxil 1. So it had rearrangements associated with Ewing sarcoma and rhabdomyosarcoma, alveolar rhabdomyosarcoma. And when we did the hierarchical clustering of this, which we did several years ago, you can see what Ewing sarcoma sort of fits. You can see rhabdomyosarcoma fits. So where does this tumor fit? Right there. It has its own category. So this is an example of biphenotypic sarcoma, which is fairly rare. We've had a few of these cases in the past. We've had ones in extremities as well that express both features that go along with Ewing sarcoma, features that go along with rhabdomyosarcoma, and with it they can have translocations that are Ewing's-like, or as you can see with rhabdomyosarcoma. In the head and neck region, the rhabdomyosarcomas are considered to be neuroectodermal in origin. So that's where you see this sort of feature where they sort of cross between the two. So I think that should, well, let me show you one other thing. And this is something that you probably will not see in the future. But this is a fairly unique infantile pulmonary tumor that was first described in New England Journal in 2018. So this is a little girl. She had a peripheral lung mass. Initial diagnosis was pulmonary blastoma, not pleural pulmonary blastoma, but pulmonary blastoma like you see in the adult literature. As far as any type of fusion, not fusion, but mutation, DICER1 mutation is associated with pleural pulmonary blastoma, and CTMB, which is a beta-catenin type of gene, those were negative. So she underwent lobectomy and she underwent chemotherapy, and she's disease-free after 7 years. And with this, you have areas that show a small round cell tumor, you have areas that show spindle tumors, you have areas that show more of a appearance that you see with sort of a peripheral primitive neuroectodermal tumor, such as you see here. So this tumor actually has many different factors associated with it. It also has SMARCA4 loss with the tumor, so that's one of the features associated with it. It doesn't have beta-catenin that's rearranged to the nucleus. DICER1 is retained, so it makes that. And it has a MAP2 associated with the areas that have P and ET. They did have electron microscopy, which is really kind of nonspecific in general, and they did have areas, all the different sort of components associated with it, so they really couldn't characterize it that way. So the differential diagnosis was pulmonary blastoma, pulmonary blastoma. But in general, this is a very unique tumor. It has many different patterns associated with it. So what happened with this, is became known as basically a fetal pulmonary teratoid tumor. And so there are a few of these tumors that have been reported in literature at this point, a fairly rare type of tumor. But in case you run into a tumor that has all these different components in a young child, first of all, don't confuse it with the pleural pulmonary blastoma, and don't confuse it with the FLIP, which looks very much different. So I'm going to stop at that point.